Welcome to Roadmap to Residency. Hello everyone, I am Abhiras. Welcome to our Club 250 Maths Maker sessions. We are currently in our neurology sessions. We will be running through some questions with you guys to help you on a journey to a 250. So here we have compression of a nerve arising from which of the following locations is most likely causing this patient's recent symptoms. A 65-year-old man with a long history of smoking comes to the office due to a non-productive cough over the last several months. He recently developed left shoulder pain, persistent hiccups, and dyspnea. His temperature is 36.7 degrees Celsius, blood pressure is 140/85, pulse is 76 per minute. Physical examination reveals decreased breath sounds on the left side. Chest X-ray shows a large left lung mass. Compression of a nerve arising from which of the following locations is most likely causing this patient's recent symptoms? Brainstem, C1 to C3, C3 to C5, C5 to C8, or T1 to T2. So here we can see the patient is having hiccups, the patient is having dyspnea, okay, and the patient is having a large left lung mass too. So which of the following nerve compression can lead to these symptoms? So lung cancers are prone to early local and distant spread. Intrathoracic expansion of a tumor can cause a number of distinctive syndromes, including phrenic nerve irritation and palsy. The phrenic nerve arises from the C3 to C5 cervical segments and descends through the neck and thorax to innervate the ipsilateral hemidiaphragm. Phrenic nerve irritation can cause dyspnea, hiccups, and deferred pain to the shoulder. Phrenic nerve palsy is associated with respiratory distress and diminished breath sounds on the affected side, with elevation of the affected hemidiaphragm on chest X-ray. Upward movement of the affected hemidiaphragm with inspiration is seen on fluoroscopy. Other syndromes that may occur due to the local spread of a lung tumor include Horner syndrome, that is ipsilateral miosis, ptosis, and anhidrosis, occurs in association with tumors of the lung apex, Pankos tumor, that disrupt the oculosympathetic nerve pathway. The lung cancer in this location can also invade the rami of brachial plexus, C5 to T1, and can cause shoulder pain, choices D and E. A centrally located tumor or mediastinal spread of a more distant tumor can cause superior vena cava syndrome, which is commonly associated with small cell lung carcinoma. SBC syndrome causes headache, facial and upper extremity edema, and dilated veins of the upper torso. Involvement of the recurrent laryngeal nerve may cause hoarseness. Dysphagia may result if the tumor compresses the esophagus. Choice A. The brainstem, which is the site of origin of most cranial nerves, contains the respiratory center in the medulla oblongata and is traversed by spinal tracts. Brainstem strokes typically present with vertigo and in extreme cases can lead to locked-in syndrome, spastic quadriplegia, and paralysis of most cranial nerves with preserved consciousness. Choice B. C1 is unique among the special nerves in that it carries only motor fibers. C1 to C3 lesions could affect the neck musculature, but would not explain the patient's hiccup and dyspnea. Now let's review some of the topics from the cranial nerves first part. So there are total 12 cranial nerves. Okay, you can remember it by the mnemonic. Some say, sorry, it is the mnemonic is for the type of the sensory nerve of the cranial nerves. But the thing is that you have to remember these cranial nerves every day. You have to revise these cranial nerves every day until and unless you master the number of cranial nerves. So the thing is that the USMLE step 1 does not typically test you on the number of cranial nerves, okay? But you do have to know them, okay? Sometimes they may mention, instead, if they are so lazy to write down the name, they may mention only the cranial nerve 7 or cranial nerve 8. But what do you have to understand is that when you read it in the med school, you may read about the course and the different branches of the cranial nerves, but those things are not very high yield for the step 1 examination. What is high yield for the step 1 examination in the cranial nerve part is the function and the loss of function due to the pathology of that affected nerve. So here you can see that olfactory is the cranial nerve 1 and it helps in the smell. So if there is defect in the olfactory cranial nerve, then that will lead to defect in the smell, maybe loss of smell, or maybe the what we call is that irritant smell. The normal smell is altered. Optic, obviously sight. Oculomotor, eye movement. Pupillary constriction. Accommodation, eyelid opening. Okay. Trochlear, eye movement, superior oblique. So you know about the SO4, okay, superior oblique, Cranial Nerve 4, LR6, okay, lateral rectus LR6, and rest of the extraocular muscles is supplied by oculomotor nerve, right? So let me write down it for you so that you can make a mnemonic out of it. So you have SO4, okay, you have LR6, and rest all the structural muscles are supplied by the cranial nerve 3. So this is the superhit mnemonic about the extraocular muscle innervation, right? So let me erase this all again. Yeah, so trigeminal has three parts, okay? It has an ophthalmic, maxillary, and mandibular part. So it helps in the mastication, facial sensation, okay? Somatosensation from the anterior to of the tongue, and dampening of the loud noises by supplying the denser tympani, okay? Now the abducens supplies the lateral rectus, facial supplies the all the muscles of the face, almost, and facial movement, eye closing, it is from the anterior to of the tongue, okay? And lacrimation, salivation. The taste is from the chorda tympani. This chorda tympani, the name is typically very important in the facial nerve part. The vestibulocochlear supply helps in the hearing and balance. Glossopharyngeal helps in the taste and sensation from the posterior one of the tongue. Now, the taste and the nerve supply of taste and sensation of the posterior one part of the tongue is very important, or the nerve supply of the tongue is very important. So the anterior is supplied by the cranial nerve 5 and cranial nerve 7, and the posterior is supplied by our glossopharyngeal nerve, that is the cranial nerve 10. Now, can see it also helps in monitoring the carotid body and sinus and cavern baroreceptors. So vagus helps in the taste from supraglottic region. Okay, now you can see 5, 7, 9, and again now this is the supraglottic region, and now this part is supplied by the cranial nerve 10. So now you uh, know about the different nerves supplying the tongue. So we have 5, you have 7, you have 9, and you have 10. Okay, now Foster also has a very good picture of the tongue, and it will be very helpful in remembering the different nerve supply of the tongue. Now, the accessory cranial nerve, that is the cranial nerve 11, helps in head turning and shoulder shrugging, okay? And hypoglossal nerve helps in the tongue movement, guys, okay? Right. So let's discuss further. Yeah. So now here we can see the upper motor neuron lesion and lower motor neuron lesion of the facial nerve typically. So upper motor neuron lesion is when the motor cortex, connection from the motor cortex to the facial nucleus in pons is lost. Anywhere between these, if there is the lesion, then that is called as the upper motor neuron lesion. If it is in the facial nucleus or anywhere along the cranial nerve 7, then that is called as the lower motor neuron lesion. The affected side is the contralateral side, okay, and the affected side is the ipsilateral side. Now, the muscles involved are the lower muscles of the facial expression and the upper and lower muscles of the facial expression. Forehead involvement is spared due to the bilateral upper motor neuron innervation, and forehead movement is affected. Now, the other symptoms include, depends on the size of the lesion, and other symptoms include incomplete eye closure, which can lead to dry eyes and corneal ulceration, hyperacusis, loss of taste sensation to anterior tongue. Now, this corneal ulceration may be a hint which can give you that the patient has a lower motor neuron lesion type of facial nerve palsy that is from the long time. Now, here you can see that this is the facial nucleus. Now, this has the upper division, and this is here the lower division. Now, here you can see that this is the face area of the motor cortex, and this is also the face area of the motor cortex. So You can see that the upper division has bilateral innervations from this side too and from the green side too, okay, both from the green side. Now if there is lesion here, then that will supply the upper neuron division is supplied by uh, the part of the on side, okay. For example, if there is lesion on the right, let me again write it. Lesion on the right side, for example, okay, then the left side is supplying the promoter neuron division, okay. The left side is supplying here, and now that's why the forehead part is not involved in case of upper motor neuron type of lesion. Now if there is a lesion in the facial nucleus itself, then that will or if there is a lesion in the facial nerve here, if the facial nerve is cut, then both upper and lower are lost. So that's why whole of the face, whole of the half face is involved typically. So I hope you have understood that if there is lesion in the upper motor neuron type, then that will spare the forehead, and if the forehead is involved, then that means that the lesion is there in the lower motor neuron system. Very high yield topic for the step 1 cranial nerve part, very frequently tested. Now, let's discuss about some of the other high yield common cranial nerve lesions. So, cranial nerve 5, jaw deviates towards the side of the lesion due to unopposed force from the opposite pterygoid muscle. So, again, for example, this is the jaw, okay? This is the jaw, okay, guys? This is not a tongue, okay? This is a jaw. For example, this is a jaw. Now, if there's lesion on this side, okay, now this side muscle is lost. So what happens is that in the normal position, forces from this side of pterygoid muscle, forces from this side of the pterygoid muscle, and the jaw is in midline. Now when the function of this side of pterygoid muscle is lost, then this is pushing the jaw to this side, okay. Now left side is pushing the jaw to right side. So that's why if the lesion is on the right side, then the jaw will deviate towards the right side, okay. Now let's move forward. Can an obtain lesion? Uvula deviates away from the side of the lesion. Weak side collapses and uvula points away. Canal of 11 lesions. Weakness turning head to the contralateral side. Shoulder droop. Canal of 12 lesion. Lower motor neuron lesion. Tongue deviates towards the side of the lesion. Facial nerve lesions. Bell's palsy is the most common cause of peripheral facial palsy. It usually develops after the herpes simplex virus reactivation, treatment is glucocorticoids or acyclovir. In addition, most patients gradually recover function, but aberrant regeneration can occur. Other causes of peripheral facial palsy include Lyme disease, herpes zoster, sarcoidosis, tumors, or diabetes mellitus. Now let's discuss one more question here. So injury to which of the following cranial nerves is most likely responsible for this condition? A 34-year-old man comes to the clinic with a 3-week history of difficulty hearing. He finds it increasingly difficult to tolerate everyday sounds. He also complains of ear pain and often avoids public places as a result. The patient has no past medical history and takes no medications. An injury to each of the following cranial nerves is most likely responsible for his condition. Now, if you can remember the cranial nerve chart that I have shown you in this video, then you can answer this question so easily. So, accessory, facial, glossopharyngeal, hypoglossal, or vagus. What do you think? Pause the video and try to answer. So let's talk about some of the middle anatomy. Here you can see that this is the tensor tympani muscle, okay? And this muscle involvement is what is we are going to discuss in this system, okay, in this question. Also here you can see this is the stapedius muscle, right? So, and here you can see the peripheral facial palsy figure again, loss of forehead and brow movements, inability to close eyes and drooping of the eyelids, and loss of nasolabial folds and drooping of the lower lid. So the middle ear cavity contains 3 auditory muscles, malleus, incus, and stapes. Okay, 3 auditory ossicles and 2 skeletal muscles, tensor tympani and stapedius, that participate in the transmission of sound from the tympanic membrane to the cochlea. The stapedius muscle arises from the wall of the tympanic cavity and inserts into the neck of the stapes. Now, this is innervated by the stapedius nerve, which is a branch of the facial nerve. Okay, cranial nerve 7. Okay, now the important muscles now have become tensor tympani and stapedius muscle. Now, stapedius muscle although being very, very small muscle, one of the smallest muscle in our body. Now, this is very, very important in sound modulation. Okay, so what happens is that uh, this the eardrum collects the sound, okay, and due to the lever mechanism, okay, that you will study in the step 2, this is the lever mechanism, the sound intensity increases, okay. Now the stapedius muscle controls the beating of the stapes bone also. That's that is how you control how much sound actually gets transmitted into the inner ear. And that's how, if it is lost, then the patient will have increased intensity going in, and the patient will have difficulty in hearing. Now, the stapedius muscle functions to stabilize the stapes. Paralysis of this muscle, secondary to an injury to the lesion to the facial nerve, causes the stapes to oscillate more widely, producing hyperacusis. Now, patients will typically complain of increased sensitivity to everyday sounds and will often withdraw socially as a result. Treatment consists of refraining from the sound using broadband noise, example white noise. The tensor tympani muscle arises from the cartilaginous portion of the auditory tube and the adjoining part of the sphenoid bone and inserts into the malleus. It functions to contract the tympanic membrane medially, thereby increasing its tension and dampening the sound transmission. It is innervated by the mandibular branch of the trigeminal nerve, Cranial Nerve V3, and ipsilateral hyperacusis is common findings with Bell's palsy, unilateral peripheral or facial uh, paralysis. Thank you for watching. Keep studying hard.